So what do you remember from your initial EMT education program when your instructor gave you a lecture about documentation? I bet they used the phrase, if you didn't document it, it didn't happen. It's very common. You've heard it a million times. But I always wonder, what do students actually take away from that statement? If I transported a patient to the ER and they had a spinal injury, and I put a C-collar around their neck and took spinal precautions on that patient, but I didn't document in my report that the C-collar had been applied, does that magically make the C-collar disappear and not exist? So it's a struggle to get through to the student what this phrase actually means. Now, in my experience, it's twofold. What your instructor in your EMT program probably told you is that if you are ever in a deposition or on the witness stand in court and you're being cross-examined, you will only be able to testify as to the information contained in your written report. All right. A good attorney is not going to give you a chance to explain anything. They're going to ask you straight yes and no questions to basically discredit you as a healthcare provider if that is their intent. So that's why it's important to document everything in your EMS report, your patient care report. Now, I have another way of looking at it. My way of looking at it is most of you will remember when you were in high school and you had a curfew and you might have been out with your friends on a weeknight, hanging out, having a good time, and it's getting close to your curfew, and then suddenly you go to leave and your friend's car won't start, and you realize, oh boy, we're going to be late. I'm going to get home after my curfew. At this moment, you have two choices. You've got a fork in the road, right? You could, these days you could text or call your parent on your cell phone. When I was a kid, we had landlines, so I would have had to call from a landline to let my parent know that I was going to be home after curfew and, just take the heat or whatever I need to at that point. But just so my parent wouldn't worry about me or, think I was dead in the ditch or something or not respecting their rules. Or you could just wait until you got home. 10 o'clock on a weeknight, maybe mom or dad just went to bed and you can sneak in and they won't be the wiser. So there was always a chance that you might get away with it. So, you understand what the more responsible decision would be, right? It would be to, be transparent. Text or call your parent and inform them of the impending curfew violation. All right, because if you get home without having called ahead and your parent finds you coming through the door, they're not likely to believe your story about there being car trouble and you being home past curfew was unavoidable, right? It's the point that I'm trying to make here is that I am less likely to believe your story if I have to ask you to explain to me what happened because you weren't forthcoming in your report. If you documented everything correctly in your report, then I should have no reason to doubt what happened on the call. If it's unclear, if you checked a blood sugar or you applied a C-collar and I have to ask you about it, did you really do it? Or are you just telling me that you did it because you realize that you should have done it and you didn't do it and that was a mistake? This is the kind of doubt that a good attorney is going to exploit and cause the jury and the courtroom to have questions and concerns about your credibility as a witness. If you document it thoroughly, then there's no question what happened on the call, and you will be seen as a credible witness. Other reasons that it's important to document is, you're writing that report for someone who's not there. They can't see what you see when you walk in that room and you look at that patient and you see that their arms and legs are contracted and there's simply no way that person was going to get to the hospital by any other means other than by you picking them up and placing them on your cot and transporting them to the hospital in your ambulance. So that's why it's important to document, the presentation of the patient. The way that you use language, the way that you use medical terminology paints a picture of your competence as a healthcare provider. If you struggle to, put a sentence together or to spell words properly, then whoever reads that report later on, if they've never met you before, they are forming an impression of the quality of work that you do based upon your narrative and your documentation. And if you aren't good at documentation, they're likely to believe that you probably aren't good at providing care either. And it works the same way. If you are really good at writing, narratives and using correct medical terminology and, phrasing and everything, then even if you're a mediocre EMT or paramedic, you look like you're dynamite in your documentation. I wouldn't be making this video right now if it wasn't a key component for reimbursement. Documentation is vital to us being able to recover the work that you've done through a healthcare claim. And then finally, if there is a bad outcome, and this is a real stretch, but this is what the EMS instructors always use to make an impression on the young EMT or paramedic, it's that if you don't do good documentation, then you're going to end up in court on the witness stand, and you're going to look like a fool in front of the entire room because of your documentation. Now, at my agency, we use a method called DACHART. There's many mnemonics out there for EMS report composition. We use DACHART. We literally put the letters into our narratives. So it breaks out each section. All of the narratives appear to be uniform the way that they're laid out. It's very easy to find the correct information. But it's also very likely that if you're not using it properly, you're going to have a very disjointed and chronologically confusing report. So let's go over each component of DACHART so that we're all comfortable with writing this report. D is dispatch information. Chiefly what I'm looking for is what priority you responded. You can say priority 1, priority 2, priority 3, priority 4. You can say emergent or non-emergent, but just to give me the indication of, was it an urgent call or was it a non-urgent call? What was the nature of the complaint? All right, now this would be what dispatch gave you as the reason the person called 911 or why the ambulance was requested. Okay, now if you're an experienced provider, you know that often when we respond to a 911, what we're told by dispatch is not what we find when we arrive. But we respond and we also bill according to the complaint we received, not necessarily the actual problem the patient had. So including the nature of the complaint, again, builds the picture of the situation through the eyes of our dispatch and the urgency of our response. What type of scene was it? Was it a private residence, a single-family home, an apartment, a parking lot, a commercial building? Okay. Now you don't know that while you're responding, but you're not writing this report while you're responding. You're writing the report after you've arrived and done your assessment and probably delivered the patient to the hospital. And then finally, if there is any kind of need to stage because the scene isn't safe or there's a delay reaching the patient because of time, distance, weather, etc., this is a good place to mention that. So here's an example. We're going to build this report gradually. We are dispatched for an emergent response to an assault at Big Daddy's liquor store. Scene not secure. Staged in Jalapenos parking lot on Baldwin. Dispatch advised, cleared the scene at 21:46. Next section is A for appearance, or sometimes people call it arrival. But basically, what you're doing in this section is you are painting a picture of what you saw when you arrived without any kind of foreknowledge, without any kind of interview or assessment of the patient done yet. What do you just see as you approach the scene? Where was the patient found? What position was the patient found in? Other responders present, police, fire, nurses, etc. What were they doing? Were they standing around the patient with their hands in their pockets, or were they, actively assisting the patient, delivering any treatment? This could be one or two sentences, or it could be very complicated depending on the situation. Imagine a car accident, okay, with multiple cars involved, damage to the car, etc. Where was the patient found in the vehicle? Don't assume they're the driver, right? They could be in the back seat, they could be a passenger, again, conscious, unconscious. What kind of damage is apparent to the vehicle? Do they have a seatbelt on? Were the airbags deployed? Etc., etc. Cardiac arrest, okay? Is the patient just laying there on the floor and nothing is being done? Or perhaps there's a first responder there with a barrier mask and an AED. Or maybe there is a Lucas device and an AED and a BVM and an advanced airway, okay? Again, this is very important to identify what care was being delivered before you arrived. So, arrival. White male in his 20s presents alert and ambulatory on the sidewalk outside of store. Oakland County Sheriff's Office and Waterford Township Fire Department personnel on scene prior to arrival. Patient appears agitated and is yelling at bystanders as we approach. Next section is C for complaint. Now, this is important to understand. We're not looking for an impression or a diagnosis. Literally, what we're looking for here is what does the patient say is going on when you ask them, what happened today? Okay, what's the matter? So you can use the patient's own words, or you can dress it up, but just understand it's not a diagnosis. In my career as an EMT and later a paramedic, I have never gone into a nursing home and walked into a patient's room and had the patient tell me, "Hi, I've got a deep vein thrombosis in my right leg." Okay? What they say is, my leg hurts, or my leg is really hot, or I don't know why you're here. So again, it's the patient's not actually able to tell you the diagnosis. The patient's going to have a complaint based upon the symptoms. That's what you document here. Now, in ESO, our EPCR platform, there's a section outside of the narrative where you can state the diagnosis or your impression or whatever, because that's what the billing department likes. They like to have an ICD-10 code type diagnosis that they can enter. So complaint here would be a head and shoulder injury. H is for history. Now this is one of the most misunderstood and misused section. Often EMTs and paramedics think of medical history when you say the word history, right? So I see in this section very commonly things like high blood pressure, congestive heart failure, hyperlipidemia, diabetes, stuff like that, okay? That's not where that information goes. There's a section in the patient tab of ESO where you put their medical history along with their medications and allergies. What we're looking for in the narrative is what were the sequence of events that led up to 911 being called, or if the patient happens to be a non-emergent patient in the hospital being discharged, what were they admitted to the hospital for? What were they being seen in the hospital for? What kind of tests, evaluations, surgeries, etc. were done on them in the hospital, right? But we're looking for kind of a sequence of events that led up to 911 being called here. So in this case, per the deputy, patient had bought some beer and was having a verbal disagreement with another customer as he was leaving. Patient was struck from behind and knocked to the ground, then kicked in the head, and his beer was stolen. Sad day. No weapons were observed. Bystander called 911. Patient is not cooperating with deputy, and above information came from the store employee. Okay, this is a frequent situation when people are, emotionally distraught. They don't really want to talk about what happened, especially with law enforcement there. So, we get information from various sources. History can come from bystanders. History can come from the patient, their family, etc. After history, we have A for assessment. Okay, now you don't have to be redundant. If you did a good assessment in the head to toe section, you can get very detailed in the actual physical exam section of ESO, where you can do your eyes, ears, nose, throat, lung sounds, upper or lower, abdominal quadrants, etc. So I'm not looking for a lot of redundant information here. What I'm looking for is really specific information in regards to the patient's complaint. You don't need to tell me in the narrative section what the patient's vital signs were, or that you even took vital signs, okay? I can look in the vital signs section and clearly see that vital signs were done. So it's just a waste of keystrokes to write vital signs taken or whatever. You can address pertinent negatives here. If you have a patient who's, for example, in a car accident, before we move that patient, you want to check, hey, do you have any neck or back pain? Can you move your arms and legs? Do you have any difficulty in breathing or chest pain from the seatbelt? Did you lose consciousness? Things of that nature. Remember the acronym OPQRST. This is very helpful when it comes to a pain assessment, which is very frequent when the patients are injured, okay? Anytime the patient has any kind of injury or maybe a chronic or acute pain complaint, you want to use the OPQRST mnemonic to be specific about in your assessment and be targeted in your assessment on exactly where the pain is, where it's going, how long it's been going on for, is it constant, does it come and go, what's the quality of the pain, is it stabbing, is it pressure, is it an ache, make sure you get a number on it. That way, on a scale of 1 to 10, you know if anything that you do subsequently is going to improve that pain or hopefully not make it worse. So be specific. Things like back pain are too general, especially when it comes to getting paid by the insurance. You need to be specific, like where in the back exactly was the pain. Now, frustratingly, a lot of patients are unable to pinpoint pain, okay? They're very impatient and short during the assessment. They may say stuff like, well, it's just all over, okay? Well, that's okay. You can say that it's global pain, but again, the question needs to be asked, so we've addressed it. So again, back to our assessment section. Patient is highly emotional, pacing around the scene, difficult to calm down so an assessment can be done. Patient is reluctant to accept help. Abrasions and redness on his upper back and neck. Pain also noted on palpation of occipital region. Pain is rated at a 5 overall. Neck pain is localized midline. ETOH odor noted on his breath. Patient admits to having a few alcoholic drinks earlier. Denies any loss of consciousness. Able to answer orientation questions after a few wrong guesses. Pupils are equal but sluggish. Patient advised he needs to get evaluated at emergency department, but is presently refusing transport. Okay? So very important that you understand that assessment can be ongoing. This is just the assessment that we did on the scene, okay? And keep that separate from any treatment, which is next. So we have treatment section. In ESO, there's a flow chart, which is where we can kind of chronologically chart every possible treatment that we could deliver to a patient. That's allowed by our protocol. This flow chart, it's very important that we use it and accurately chart all the treatment delivered, because presently your narrative section is not searchable. So if there needs to be any kind of study or report pulled based upon, the patient's complaint, or based upon, the pain management that you've done or whatever, writing that you started an IV and gave fentanyl for pain in the narrative is worthless. It's worthless to anyone doing any kind of study or report, because that tool cannot search your narrative for information. They're looking for information in the flow chart. So very important, document in the flow chart. Now for EMTs in this area of work, which is, or I should say my area of work, which is private EMS, often we're not doing treatment. We're taking people home from the hospital, we're taking people from the nursing home to their dialysis appointment, we're taking them to doctor's appointments and stuff like that. But one thing that needs to be identified in the treatment section is how you moved the patient to your stretcher. Was the patient able to stand up from bed and walk to your stretcher? Okay, they shouldn't do that, because that really undermines the need for the ambulance crew. If the patient can walk, why can't they walk to the curb and get into an Uber? All right. So if we document that we had to extremity carry the patient from their bed to the cot, or we had to sheet drag them or whatever, that reinforces the patient wasn't otherwise able to get up and move themselves. So it's very important to document that in your narrative section. Now, somewhere in the assessment or the treatment section, you need to make a statement of medical necessity and explain why does the patient need to go by ambulance above all other means. This is very important. It's less difficult in a 911 emergency call than in a non-emergency call, because generally in 911s, the need for the patient to go to the hospital and be seen by a physician is pretty obvious. There is, bleeding going on, there's a great amount of pain, there's chest pain, difficulty breathing, etc. Whereas if a patient's being discharged from the hospital, they're leaving the hospital, which means that they're stable. So now, where's the urgency? Where's the need for that ambulance crew and that cot, right? That is your job as the EMT or the paramedic author to explain in this section. And then finally, make sure that you are treating the patient per your local protocols and not simply doing things because, well, that's what I've always just done in that situation, because that's how my partner trained me, to do these things. We've all made the mistake of listening to our partner and believing what they say simply because they have more experience than we do, or they've worked at this agency longer than we have. And we treat whatever they tell us as gospel. Well, what I'm always curious about is, where did they learn that? Who told them that? Is it something that was simply told to them by the person who trained them, who was trained by someone else, who told that person everything, and it just got passed along like a game of telephone, and no one actually knows where it's written down? Okay? See the problem here? If nobody knows the source of the authority for why we are doing this treatment, then you're really sticking your neck out. So whenever your partner tells you something and it doesn't ring true to what either you've read in your protocols or you've even seen in an EMS textbook, then ask them, hey, where'd you learn that? What's your source? Okay? Because if you go around treating a patient based upon something someone told you in a certain circumstance, maybe it was a doctor, maybe it was a nurse, maybe it was a paramedic with more experience than you, okay? But if there's a bad outcome, I guarantee you that that doctor or nurse or paramedic is not going to show up in the courtroom and inform the jury that they misled you or they told you something and it was taken out of context or whatever. All right. So make sure of the justification that you're using for your treatment comes from an authority such as your EMS protocols, or better than nothing would be an EMS textbook or some sort of written format. Moving on. So in this case, because the patient had been drinking and was refusing care and needed to be seen in the hospital, our protocol directs us to contact medical control for direction as to if we can transport that patient or not. So in this case, McLaren Oakland Hospital Emergency Department contacted, gave a report to Dr. Eisenberg, advised that the patient does not want to seek medical attention at a hospital. Possible ETOH and or head injury also related to the physician. Eisenberg directly addressed patient on speakerphone, advised him of possible fatal consequences of refusing transport. Patient then agreed to transport. Patient refused C-collar, however. Risk explained to patient, who continued to refuse. Treatment refusal signature collected while Eisenberg online. Medical control terminated and patient packaged on cot for transport to McLaren Oakland Hospital. So, couple things in here. We're very versed at doing refusals of care, but if a patient refuses treatment, this should be documented and a signature should be collected from the patient to acknowledge that the treatment was offered and the patient declined. Make sure that we document that we've informed the patient of the risks of refusing treatment, and you want to always make sure the patient is making an informed decision by letting them know why it's important that we do this treatment. So for this, all right, last section. T is for transport. Now, the transport section encompasses everything that happened after transport was initiated. It serves to draw that dividing line between the assessment and the treatment that was delivered on the scene, and then the assessment and treatment that was continued as you transport it. So it's very important chronologically to understand that the reader, if you put all the treatment in one section and then go to transport and say we transport to the hospital, and it doesn't appear that you did anything else for the patient during that transport. So that's why we put continued reassessment and treatment in the transport section. We should include the destination, the hospital that the patient requested, or perhaps the hospital that we were directed to take the patient to per protocol. Perhaps the closest hospital wasn't the most appropriate hospital for the patient's complaint. What method or medium did you use to notify the hospital that you were bringing them a patient? Here in my county, nearly every hospital requires us to contact them and give them kind of a heads up that we're bringing them a patient. This harkens back to the days when it wasn't uncommon for ERs to fill up and for them to not have enough room to accommodate more patients. It just was better for the patient to drive another, half hour down the road if they could be seen, 2 hours sooner than an overcrowded closest hospital would. So we always document how we contacted the hospital, whether it was by phone, by radio, or our newest tool, eBridge. And then when we arrive at the hospital, we don't just find an empty bed and shove the patient over and leave, right? We've got to talk to somebody. We've got to give a report. So who did you give a report to? Specifically, I want their name. Protocol used to require us to collect a signature from the person that we gave report to. That's no longer required, but it is helpful to get someone's name. Just simply because I want my EMTs and paramedics to learn the names of the, their counterparts in the ER. They're going to see these people repetitively, and if you call someone by their name as opposed to calling them the nurse or the doctor or whatever, then you build rapport with them. And they're going to make an effort to learn your name, and now you're no longer just the ambulance driver or the EMT or whatever. You're a real person to them as well. T, transport initiated. 2 minutes from hospital, patient said he didn't feel good and stopped answering questions. This was shortly followed by a tonic-clonic seizure. Transport was paused so 10 milligrams IM Versed could be given. Convulsions ended after around 60 seconds of seizure activity. Vitals reassessed. Patient is breathing on his own, but due to hypoxia, patient given O2 via nasal cannula. IV started as precaution. Transport resumed. Upon arrival at MOH, the patient is still postictal. Staff advised of seizure, and patient transferred to trauma 3 bay. Patient began to regain consciousness when moved to hospital bed, opening eyes but no verbal response. Incontinence noted. After patient moved to hospital bed, he abruptly sat up and attempted to get off the bed despite verbal warnings. Patient pulled off nasal cannula and became violent with staff. EMS crew assisted with patient restraint and gave report to Dr. Eisenberg. Security arrived and relieved EMS. End of report. Some EMTs or paramedics put their initials at the end. I put EOR. It just kind of ties a knot in the whole thing and says, this report is finished. I've said everything I intended to say. I just didn't, forget to finish writing the report at this point, and I left stuff out. I also do want to acknowledge in this example that any patient that received 10 milligrams of Versed post-seizure is not going to wake up and start fighting in the ER. I just thought it was a more exciting conclusion to this report. Now, I always show this EMS narrative to all of my orientation classes as an example of how not to document stuff, or what can go wrong if you're not doing good documentation. So this is getting kind of old now. It's currently 2025. This report, I believe, was written in 2010, but let me paint the picture a little bit here. So in Oakland County, Michigan, about 8 years ago, we had a 2-paramedic rule on the advanced life support ambulances. This means that every ambulance had to be staffed by 2 paramedics, and you couldn't split it with an EMT. So if you were an emergency medical technician in Oakland County 8 years ago, working for a private ambulance service, then you could only work with another basic EMT. And basic EMTs go on basic EMT calls, which would be hospital transfers, dialysis calls, psychiatric transports, etc. So all of those acute assessment skills and things of that nature that were really drilled into you in your EMT program. And you can remember those National Registry skill sheets that you had to memorize and go through in scenarios. Well, all of that assessment knowledge and critical thinking would just rust and crumble, and you would get used to just doing things how you always did them, which is you pick the patient up and put them on the stretcher, you put the stretcher in the ambulance, and you drive the ambulance to the hospital, and nothing exciting ever happened, okay? It lulled us into a false sense of security that, again, it's always going to be the same. There's no need to ask too many questions because nothing ever happens, so who cares, right? After you write 150 transfer narratives, they all kind of blend together. Well, in this case, we had a private caller who she specifically said she did not want to call 911. She did not want the local ALS fire department to respond to her home because her mom had fallen and probably broken her arm, and she wanted her mom taken to the hospital. Now, she assured our dispatchers that she was a nurse and that she had, checked her mom out and she's fine, she's not dying, she just needs to go to the hospital and get an x-ray. And in fact, she actually put a splint on her mom's arm herself. So she said, I just need an ambulance to come transport my mom. Can you send me an ambulance? And we're like, no problem. So we sent an ambulance with a basic crew because it sounded to us like the patient was stable. So we send the ambulance. Crew gets there and they do what they've always done, which is to pick the patient up, put them on the stretcher, put the stretcher in the ambulance, and drive them to the hospital. Well, this time things were a little different, but they had lost that critical thinking that is drilled into new EMTs because they had just repetitively done the job for too many years. So we are going to go through this narrative twice. The first time I want to go through it, we're going to talk about the DACHART format and identify, did this EMT follow the DACHART format correctly, or did they put information in the wrong section? And then we'll go through it one more time. After that, you've had a chance to digest it now, and we'll now identify all of the factors that the EMT missed. The EMT should have addressed but didn't. Okay, so D for dispatch information. I said it contained three things chiefly. It would be a response priority, a dispatch complaint, and some sort of identification of the scene, a description of the scene. So we have 503 dispatched 2B to home address for patient who fell requesting Crittenton. Priority 2B, that's in there. Home address, so that's kind of your scene description. And then the complaint is a patient who fell. Now, it reads kind of awkward, but it contains the components I asked for, so I'm not going to get too worked up. So next is appearance, okay? Arrived to find 83-year-old female lying on the couch. Patient has obvious swelling and bruising above left eye and possible left wrist fracture. Patient is ambulatory with assistance. Patient assisted to stretcher via wheelchair and assistance ×2. Patient secured to stretcher ×3. Side rails ×2. Okay, so they jumped right from appearance, which is the patient's lying on the couch. You can see the swelling on her face, and you can see that she's got a splint on her left forearm. Okay, so a possible left wrist fracture. Then they jump right to treatment. Okay, so they went from appearance right to the treatment, which is how they got the patient to the stretcher. So that all that information about the patient's ambulatory assistance, that all should be in the treatment section. The patient secured to stretcher ×3, side rails ×2. Some of you might scratch your head about this, but stretchers or ambulance cots these days have 3 crossbody straps, and they have 2 shoulder straps on them as well. This crew had 3 seatbelt straps, right? And they raised the side rails ×2. That's what that means. Now, I think that, and I will argue that saying that the seatbelts were placed on the patient and the side rails were raised ×2, that's one of those things that I don't believe is necessary, okay? And the reason that I say this is because when would you ever transport a patient on your cot and not put the seat belts over the patient and not raise the side rails, okay? Do we have to document that we closed the back doors of the ambulance before we drove it to the hospital? Do we have to identify that we stopped at red lights and waited for the signal to change to green before we proceeded? Okay, it's obvious that we would put the seatbelts on the patient and raise the side rails. Now, if the patient at some point fell from the stretcher during transport and broke their hip, okay, as a result of the fall, would we be able to avoid liability by documenting the patient had all the seatbelts on and the side rails up? No, no one would believe the patient could have fallen off the cot and broken their hip if the seatbelts had been secured and the side rails were up, okay? Now the patient could have removed those and then fallen off. That should have been documented, right? Because we're always going to be sitting with the patient. But to me, stating the obvious, like putting the seatbelts on the patient and the side rails up, that's wasted keystrokes, okay? That's how I see it. You may differ, your agency may differ, that's fine. Follow your local procedures. I'm just trying to make a point. All right, continuing, complaint. All right, patient fell about 30 minutes before EMS arrival, has possible left wrist fracture and obvious swelling and bruising above left eye. Okay, now, if the patient had fallen and tried to stop herself by putting out her arm and all she accomplished was that she broke her arm and still hit her head, what would she complain of? Okay, that is what the complaint should be. It should be head and left arm pain. Okay, that is what she would tell you is wrong when you ask her, what happened today? Okay, so not this whole story. Now this fell about 30 minutes before EMS arrival. That actually belongs in the history section. That happened before we got there. Okay, that's not a complaint. And then the left wrist fracture and obvious swelling, that's assessment. Okay, now next section is history. Patient has history of dementia. All right, now you will remember when I talked about history, I specifically told you that the history section was not medical history. It was not high blood pressure, congestive heart failure, diabetes, etc. Okay, now I'm going to walk that back because now we have a situation where we have a patient who fell and struck her head. Okay, she's ANO ×2, but she has dementia. So, is she ANO ×2 right now, meaning not completely alert, because of the dementia, or because she has a head injury from the slip and fall, or the fall, right, from hitting her head? Very important. Now, we commonly get people calling us and saying, hey, can you take my mom to the hospital? She's just not acting right. Okay. Now, if we were to take the patient to the hospital and tell the doctor that, the doctor would look at us like, you know, we're fools and say, well, I've never met this person before. So how do I know how she normally acts, right? We should ask, what does the patient normally, understand? What is their normal baseline level of consciousness, and what has changed since then? What has changed because of this event, okay? That is the question that needed to be asked in this situation. Instead, they just wrote the patient has history of dementia. Now again, dementia is pertinent. I will not criticize them for putting the fact the patient has dementia in there, but it needs more detail, right? Dementia can cover a wide range. You can have a little, early forgetfulness, and then you can have patients that are so, inhibited by the deterioration of their brain that they can't even speak anymore. They just kind of stare and drool. So it's important to expand on that. Next section is assessment. Patient is A&O times 2. They don't really identify what the patient could tell them versus what they couldn't be told and stuff like that. Vitals are stable and noted. Well, I can just look up in this report and see the vital signs section, so that's a waste of time. Patient's family had Rost splinted prior to EMS arrival. That would be in the history section, not in the assessment section. It happened before we got there. All right. I think you're starting to get a gist of how to write a DACHART report now, aren't you? Next section is treatment. Patient paced in position of comfort and given ice pack for head injury, right? That is treatment, okay? I can't argue with that. It's not good treatment, but it is treatment. Transport. See, patient transported to Crittenton ER and monitored throughout transport. Now, this is another area that I'm going to have a quibble with, okay? Monitored throughout transport. Those are the 3 most worthless words that you can put into a report, okay? What else are you doing in the back of the ambulance with the patient except monitoring them? Would you ever document that you ignored the patient during transport? Would you ever document that you rode up front and left the patient in the back of the ambulance by themselves? Okay, of course you're going to monitor the patient throughout transport. That statement adds no value to your report, okay? This comes from a tendency of EMTs to add extra words to the report to make it look like it's more robust when they actually haven't added anything of substance, okay? It's what I call filler. It's kind of like the French fries that come with your hamburger, okay? It's there to fill you up after you've eaten your hamburger if you're still hungry, okay? I don't want French fries, all right? I want ground beef, okay? I'm here for the meat, and the meat is going to be, why does this patient need to go to the hospital in an ambulance attended by a licensed EMT as opposed to any other means? That is your job to identify, period, okay? So get rid of monitor throughout transport, okay? You may remember, again, it's 2025 right now. I believe that it was 2023 when those 2 EMTs down in Indiana showed up for that gentleman who was having alcohol withdrawals, and Earl Moore Jr., that was his name, Earl Moore Jr. And you may remember the police body cam footage of the EMT crew showing up in the middle of the night. The police who were there were professional, and they were empathetic, and they were helpful. And the EMTs came in, and they were obviously disgruntled and unhappy to be there. They proceeded to force the patient to walk outside to where the cot was, and then they placed the patient face down on the cot. Okay, and if you watch the body cam video, they first of all, they forced the police officers had to step in, and they carried the patient out themselves instead of the EMTs. And then the male EMT almost body slams the patient face first, prone on the cot, okay? And then they secure the straps over the patient's back and load the patient in the ambulance. Now, at some point during that transport, the patient went into respiratory arrest. And by the time the patient was in the ER, he was in cardiac arrest, okay? Now, I don't know if he went into cardiac arrest while the EMT was monitoring the patient throughout transport, okay? But if the EMT had documented that as a defense and the patient arrived in the ER deceased, do you think that would go over with the jury? Do you think they would buy that? No, of course not, okay? So you can't claim to monitor the patient throughout transport and expect that to be any kind of help to you if there is a bad outcome. Finally, report was given to ER staff and care transferred, 503 clear, okay? Now, this is a horrendous narrative. Not arguing that at all, okay? But it's very helpful because it does spark the conversation of what would we document if we were called, okay? If we were the ones responding to this call and transporting this patient to the hospital, what questions would we want answered, okay? So I'm sure some of you guys out there in YouTube land are waving your hands around and banging on the table and yelling like, what about blood thinners? What about a head injury, right? That's one of our chief worries with an elderly patient who has fallen and struck their head. If they're on blood thinners, that is going to make it far more likely the patient has developed a brain bleed, okay? It's going to cause a lot of complications, and it's going to definitely increase the urgency of transporting this patient to the hospital. You know, the hospitals have benchmark times that they need to meet when patients come in with certain trauma criteria. And in this case, this crew did not recognize, even though they documented the patient's medications, that the patient was on Coumadin, okay, and that the patient had fallen and struck their head. How did the patient fall, okay? It never identifies how the patient fell. Now, do we just assume the patient tripped and fell because that's the most common way people fall? Well, what other ways can people fall? Well, she might have gotten dizzy and fallen, okay? She might have had a syncopal episode, passed out and fallen. Maybe her blood sugar got low, okay? Again, they never asked that question, all right? So very important questions to ask. Was it a witnessed fall? What did she hit? Was she in the bathroom? Was she in the kitchen? Did she fall and hit carpeting? Did she fall and hit a toilet? You know, those details do matter. Another thing that is missing from this report is a stroke assessment. Anytime a patient has a new onset neurologic complaint, we should do a Cincinnati pre-hospital stroke assessment on the patient. It takes 60 seconds to run through this. Again, if the patient has a new onset fall, difficulty walking, weakness, changes in level of consciousness, we should do a Cincinnati and document a Cincinnati to rule out stroke. You don't see that done here, do you? In my county, when we have a patient who has fallen and has a spinal injury or a suspected spinal injury, we have 5 criteria that we look at. We look at their level of consciousness. Do they have an altered level of consciousness? Do they have any midline neck or back pain or tenderness? Do they have any neurologic deficit or pulses motor sensation deficit? Do they have any alcohol on board or any kind of intoxicants? And then finally, do they have any kind of distracting injury causing them pain that might cause them to not identify the pain or the discomfort in their neck or their back? Okay, if the patient is positive for any one of those 5 things, accompanied with a mechanism of injury that could cause a spinal injury, then we're going to go ahead and put a C-collar on the patient. okay? And then there is also a caveat that even if the patient is negative for all 5 of those criteria, the patient, if the patient is 65 years or older, they will automatically get a C-collar just based upon their age. So you don't see that here. There's no deliberate spinal assessment. They just help the patient walk to the stretcher and threw seatbelts on them and transported and gave them an ice pack for their boo-boo. There's the wrist. Let's talk about the wrist fracture. So you've got some sort of improvised splint made by the patient's daughter, right? What was that splint doing what a splint should do? Was it immobilizing the joint above and below the fracture? Was there any loss of sensation or circulation due to the position that arm was put in? No, they never reassessed that. They never evaluated the quality of that splint. So I wrote a hypothetical report how it should look. Of course, my camera window here is in the way, but you guys can get an idea. If you want to pause this and take a look at it, this is how I would have written this call. Now again, the patient did not suffer a brain bleed. It was in fact just a conventional transport. But if they had, these EMTs would have missed it completely. Medical necessity, again, very important. Whenever you write a report, if it's not obvious based upon the patient's chief complaint and the nature of the call, chest pain or seizure or whatever, you need to make sure that you identify why the patient needed to be transported by EMS on an ambulance cot, attended by an EMT, above any other means. Why couldn't the patient have gone by wheelchair van? Why couldn't the patient have gone by, a private vehicle? Okay, this is the EMT or paramedic's job to identify. I kind of made this up based upon my understanding of medical necessity. Okay, but it's kind of like a step-by-step work through to identify reasons the patient might need to go in an ambulance versus where they might not qualify for ambulance transport. All right, so obviously if the patient's unconscious or unable to follow commands, okay, they probably are going to need to go on an ambulance cot. All right, but if they are conscious and able to follow commands, does it cause them pain or do they get short of breath when they try to sit up? Okay, if it does cause them pain or gets them exertional shortness of breath when sitting up, then they probably shouldn't go by a wheelchair van. Okay, because they're going to try to hold themselves up in that wheelchair and it's going to be uncomfortable for them and it can lead to their condition getting exacerbated. Okay, and you also have to remember that a wheelchair van driver or an Uber driver, they're not medically trained. They're not going to be able to help this patient if they do get into a distress situation. So that patient should go by ambulance. All right. Now, if they can sit up without discomfort, can they hold themselves in that position for 2 minutes? It's kind of arbitrary, but I just said 2 minutes without using a backrest or handholds. Okay. We often walk into like a nursing home and we'll find the patient in a wheelchair, right? They're kind of reclined in their wheelchair out in the hallway, and if they can sit in a wheelchair, then why can't they go by wheelchair van? But we have to consider that the patient is in a stationary building. They're not in an ambulance. They're not in a vehicle in motion, okay? If you put that patient into a wheelchair van and the driver had to hit the brake really hard or they went around a corner really fast, does that patient have the trunk strength to hold themselves in that wheelchair, or potentially, are they going to slide out of that wheelchair and get injured? Okay, if they slide out of that wheelchair, again, you have a driver, one person. That person probably is not going to be able to get them back into that wheelchair. Okay, they should have gone by ambulance. All right, so have the patient sit up, get their back off the backrest, ask them to hold their arms in their lap so they're not using the armrests. Okay, now if that patient keeps on slumping back into the wheelchair because they can't maintain their body position without that backrest, they are not going to be able to hold themselves up in a wheelchair van. Okay, you can document that it's not safe to transport them by other means. They need to go by ambulance. Okay, this is not a courtroom. We don't have to prove it beyond a shadow of a doubt. Okay, we certainly don't want to put that patient into a wheelchair van and then risk them being injured just because we can't prove that they are going to be injured if they go by a wheelchair van. Okay, you are a medically trained EMT or paramedic. You can make this assessment. Okay, you're with the patient. You're physically with the patient making these assessments. The insurance company is not there. Okay, so in your judgment, is this patient safe to go by wheelchair van? And if they're not, they need to go by ambulance. All right, now let's say they can sit up without any assistance. Okay, we have another problem. They might not be physically debilitated that they need to go by ambulance cot. It might be that they are mentally debilitated. There are people who are very physically capable, okay, that have advanced dementia, Alzheimer's, okay. They're not aware of their surroundings, okay. They are definitely a risk that they could try to take off a seatbelt and get off the wheelchair van, or sorry, get off the out of the wheelchair, or they could try to open a passenger side door, or even distract the driver in a way during transport that's going to be a threat to their safety. Okay, so patients who are not alert and following instructions need to go by ambulance stretcher. Now, another problem is a very, very physically capable person might not be in the right state of mind. A person who is suicidal or homicidal definitely should be attended by an EMT or paramedic in an ambulance and not allowed to take an Uber to the inpatient psychiatric facility. Okay, the patient at any point could change their mind and hurt themselves, or hurt someone else if they are in a disturbed state of mind. If they are under a petition for hospitalization, then they don't have consent to refuse transport. They have to go by ambulance, okay, for their own safety. So number 7, finally, again, if the patient doesn't meet any of the other situations, do they have a condition that might worsen if they aren't closely monitored by an EMT or paramedic? Okay, and if we can't make any of these arguments, then it's probably unlikely that insurance is going to cover the transport. Now, at my agency, we're going to transport this patient regardless. We're not going to try to convince the patient that they shouldn't go by ambulance because they don't, meet medical necessity. It is the reason we're called is to transport that patient. And EMTs and paramedics aren't medical billing experts. They should not be giving the patient any kind of advice on, their insurance will cover it or won't cover it or whatever. A couple of example narratives. These are actually real narratives that I wrote. One of them is a psychiatric patient It's important if you have a psychiatric patient that you are specific about their condition, what exactly is going on with them. If you read the petition for hospitalization, it will give you specific firsthand examples of why the patient is a danger to themselves or others. In this case, I said the patient's having auditory hallucinations, hearing a voice telling him to kill or harm others at his workplace. He's also got severe depression, anxiety disorder, and made suicidal statements. Okay. Now, the patient is also completely cooperative and eager to leave. Okay? This does not mean they don't need to go by ambulance just because they're cooperative. This patient could change their mind at any minute. So it's important, just because they're cooperative right now doesn't mean they're going to remain cooperative. So I said the patient requires supervised ambulance transport due to homicidal and suicidal thoughts under petition and cert. Okay? The second one is a little more nuanced. The second one is about a patient who's got end-stage chronic obstructive pulmonary disease. She is able to stand up and pivot from the bed to the stretcher. Okay? The problem is that the effort of standing up, even though she insisted on standing up and pivoting herself, is that she gets short of breath when that happens. She has to take a rest between each move. Now, you put this patient in a wheelchair van, and she might struggle to hold herself in position in that wheelchair while the vehicle's in motion. So I made two statements here. I said the patient requires ambulance transport due to exertional difficulty in breathing and generalized weakness from chronic obstructive pulmonary disease. Patient's unable to maintain an upright seated position in wheelchair for time or for duration necessary to transport. So that was my statement of medical necessity. Again, there's multitudes of reasons that patients need to go by ambulance. You have to find that. You have to be what I call a detective. Okay, we've all played, these multiplayer online, adventure games where you're walking in a virtual world and there's, NPC characters hanging out, and you'll see one who's like, excited and waving at you. Maybe they have like an exclamation mark flashing above their head, right? And we walk over to them and we go, boop. Where's my camera? Boop. Okay. And we poke that exclamation mark, and then we get a box of text about what your quest is. Okay. I wish I could walk into a patient's room and just go up to their head and go boop. Okay. And get all the medical necessity information right there in front of me. It doesn't work that way. We have to be detectives. We have to dig into the patient's their chart, their discharge paperwork. We have to talk to their caregiver, their nurse, their family. Patients aren't always great historians. They don't always know why they can't walk anymore, or why it's not safe for them to go by a private vehicle. Okay? We have to ask questions. If you don't ask questions, you're not going to find the reason for medical necessity. And that is your job. Without medical necessity, we aren't going to get reimbursement from the insurance. Okay? We won't even bother trying to bill the medical insurance if we can't identify medical necessity in our report. So, the reason the patient needs an ambulance, which is medical necessity, and the reason we're called to transport them, their complaint, may be unrelated. All right, this is kind of a weird concept, but I want you to think about this. All right, patients might have medical necessity for an ambulance transport, and we're called for a completely different reason. But the reason we're going to chart the patient needed to go by ambulance is the medical necessity. Okay. Example would be PEG tube replacements. Okay, PEG tubes, otherwise known as feeding tubes. These are the rubber hoses that go through people's abdominal walls and their stomach because they can't swallow safely. When they try to eat food, they will choke or will get stuck in their airway. They'll aspirate it. So they have to get tube feeding. So, now, if these people are at home or in a nursing home, for example, and they're on tube feeding, they're getting like this like IV bag of nutrient solution that's kind of gravity feeding or pump feeding into their stomach. And occasionally, someone who's taking care of them is careless, okay? And they step on the tube or their leg gets entangled with it or something, and it gets pulled out. Sometimes patients pull their own PEG tubes out, but we can't just, pick it up off the floor and, rinse it off in the sink and shove it back in that hole. There's all kinds of complications that could occur if that's done. So the patient needs to go to the ER and have this tube replaced. That the crew who transports that patient to the ER, they're going to document typically the patient required ambulance transport due to PEG tube replacement, right? So at the ER, the doc will replace the tube, they'll flush it, they'll confirm it's in place and everything's no injuries sustained and yada, yada, yada. They'll call us back and say patient's ready to go back to the home or the nursing home and resume tube feeding, right? They're probably pretty hungry by now. So the ambulance crew that transports the patient from the hospital back to home or back to the nursing home, what do they document as the reason for transport? Okay, they can't document the patient needs to go by ambulance from the hospital back home due to PEG tube replacement. The tube's been replaced, okay? It's back in there. So the reason is something else. The medical necessity reason was always something else. The medical necessity reason was never the PEG tube. The PEG tube was just the procedure that was performed at the hospital. Okay, now people get PEG tubes because they can't swallow safely. Why can't they swallow safely? Well, again, being a detective, we're going to start asking questions. Do they have a stroke? So, yeah, definitely if someone has a stroke, that could affect their ability to swallow and protect their airway when they eat. And it also could affect them in other ways, okay? It can affect their ability to ambulate. It can affect their ability to exercise and to keep strong and able to hold themselves in a wheelchair or walk around or whatever. So when we question patients about their medical history and their past medical conditions, we're getting close to identifying a medical necessity reason. So again, just don't always look on the surface for the reason. Sometimes it's buried. It's like an iceberg, right? The thing about icebergs is more of the iceberg is under the surface. It doesn't look that big to the Titanic, okay? But it's huge under the water, just like medical necessity. This is a generic version of what's these days is called a certificate of medical necessity, okay? My crews call them PCS forms because back in the day they used to be called physician certification statements, okay? But whatever you call it, it's basically a prescription for an ambulance, okay? It's something that is filled out at a facility where the patient is under the care of a physician, okay? In order for us to get reimbursed by the insurance for this transport, we have to collect this form. We have to have this form on file. All right. Now, if the patient is coming out of their home, going to a doctor's appointment, we don't need this form. They're not under the care of a doctor in their home. All right. But on the return trip from the doctor's office, guess what? Now they are coming out of a facility, rather, where they're under the care of a doctor. So we have to have this form filled out by that facility. We have the hospitals and nursing homes really conditioned at this point to know that when we show up, we need this form. So they usually have it filled out for us. But sometimes they fill out the top section and they sign the bottom section, but they don't actually put anything in the middle section. The middle section is going to explain the medical necessity for the patient transport. You can literally just copy whatever reasons they put in here into your narrative in the assessment or treatment section and say, patient requires ambulance transport due to XYZ. Okay? It's just very important that you look at this form, you look it over and make sure that it's completely filled out. And if it's not completely filled out, you need to understand that you can't complete this form. This is a prescription for an ambulance, okay? If you got a handwritten prescription from a doctor for, I don't know, 10 Vicodin, okay, you couldn't legally add some zeros to that 10 and make it 1,000 because, you know, you want to have some spares, you know, just in case. All right, so just like that, we can't alter this form. You can hand it back to the staff at that facility and say, this form needs to be completed. And, you know, you might even give them some suggestions based upon your assessment, okay? You also have to make sure that your assessment lines up with what's stated on this form, okay? I've had these forms handed to me before that have completely fraudulent reasons checked off that I've recognized after I've done my assessment. So don't blindly just write on your report, patient requires ambulance transport due to XYZ, when you know you've done an assessment and you have found no evidence of XYZ. Hope that makes sense. So putting it all together, we don't want to have to send the patient a private bill. We want to be able to bill the medical insurance for the ambulance transport. But due to the massive amount of healthcare fraud out there, there are all kinds of loopholes and stuff and obstacles that are in our way that we have to make sure that we address, and we address correctly, legally, and ethically, so that we can get reimbursed by the medical insurance. When you're with the patient, when you're face-to-face with the patient, with their family, etc., this is the best opportunity we have to collect this information and to get all of our ducks in a row. If we have to call that patient a week after service, 2 weeks after service to try to collect information, you know, how likely do you think it is the patient's going to even answer the phone, let alone believe us when we say, hey, this is the ambulance billing company calling, that, you know, we need to ask you some questions about your medical necessity or update your medical insurance for our records. Okay, way too, you know, scammy, fishy of a call for a savvy person to just give out information, okay? When we're with the patient, when we're at the patient's side, that is when we have the best opportunity to collect a certificate of medical necessity, a face sheet, which is like their information sheet with their medical insurance information, which we should always confirm with the patient. Used to be that medical insurance never changed. It was the same card until you died. These days, people change medical insurance every 2 or 3 years. So make sure that we have accurate insurance information. Make sure that we have accurate contact information in case we have to follow up. Documentation has to be in place with a medical necessity reason in your narrative. And finally, signatures. Signatures are very important. Signatures have to be what's called contemporaneous, meaning they have to be collected at the time of service. We cannot go back, a month later and collect a signature from the patient for a service that we provided on a different date. We've got to get it at the time of service. Again, that is your job. That is my presentation on documentation and narrative writing. I hope you got a lot out of this. Thanks for watching, and I'll see you guys next time.